Welcome. Welcome, everyone. We'll get started in a minute. All right. Okay, well, let's get started here. Welcome, everyone, to today's webinar, What's New in Early Stage Breast Cancer, Highlights from ASCO 2025. Now, I am Megan Claire Chase, and I am SHARE's Breast Cancer Program Director and the host of our BC Life podcast. Plus, I'm also a breast cancer survivor. Now, before the presentation begins, I'd like to tell you a little bit about SHARE for any newbies out there. We're a national nonprofit that supports, educates, and empowers anyone diagnosed with breast or gynecologic cancers and provides outreach to the general public about signs and symptoms, because no one should have to face breast, ovarian, uterine, cervical, or metastatic breast cancer alone. For more information about upcoming webinars, support groups, podcasts, and our helplines, please visit our website at sharecancersupport.org. Now, we have a few housekeeping reminders for you. All participants will be muted during this presentation. So once Dr. Taiwo finishes presenting, we'll begin the Q&A discussion. Please submit any questions through the Q&A section at the bottom of the screen. We had some questions submitted with registration, so thank you to everyone who submitted those. And remember that our fabulous speaker cannot give specific medical advice, so make sure to keep your questions general. While she's speaking, I just said that. And so we also have closed captioning available, and you can enable that feature by clicking the live transcript button at the bottom of your screen and selecting subtitle option. And lastly, this webinar is being recorded, and we'll share the recording in a few weeks with all registrants, and it'll also be added to our website. So now I would like to hand it over to Dr. Evelyn Taiwo. Dr. Taiwo, the screen is yours.
Wonderful. Thank you. Thanks for having me give this talk today about the ASCO highlights. And yes, it's great to be here on a Friday afternoon. And like Megan Claire mentioned, my name is Dr. Evelyn Taiwo. I'm a breast medical oncologist at NewYork-Presbyterian, Brooklyn Methodist Hospital, with my academic title at Weill Cornell Medicine. So I'm going to share my slides and I will start the presentation. I think, given a talk about ASCO highlights is important. ASCO is the big oncology. It's the big oncology conference every year. It's international. There are doctors from different parts of the world, researchers from different parts of the world, and it's always nice to bring back what updates are, what the practice changing findings are, and bring that to patients and families of those who've been diagnosed with breast cancer or living with breast cancer. So let me share my slides. Just give me a minute here. Are you able to see my slides?
Not yet.
It says allow Zoom. Okay. Are you able to see it now? But still not yet?
Not yet.
Interesting. Okay, let's
Do you have two screens?
No, I have just one screen. I actually have it. My slides are open on my screen. I'm not sure what's going on. I will get
share if you'd like.
That may be helpful, just so we're not spending too much time trying to figure this out.
You got you covered.
Fantastic. Okay, wonderful. So here is the first slide, and I'm going to move on to the next slide, please. Okay, so I'm going to go over a few studies today, and I know the presentation is on early stage breast cancer and the highlights on early stage breast cancer, but there are too many things to just focus on early breast cancer. I will go over many of the practice-changing and impactful early stage studies, but I thought it was also important to include couple studies in the metastatic setting, as well as some studies on survivorship. So the first couple studies, I'm going to break them down by breast cancer type. I will talk first about the HER2 positive breast cancer studies, and then move on to the hormone receptor positive studies. There's a study in the metastatic triple negative breast cancer space, study on surgery, and then two studies that I will be presenting that focus on survivorship. So if we can move on to the next slide, please. Perfect. So what I found really interesting about some of the early stage studies is that we are now at a point in early stage breast cancer management where we have effective treatments. And now the goal is really focusing on how do we de-escalate treatment, which I think is always a good thing. You know, we have these drugs that are very effective in shrinking tumors, in reducing the risk of cancer recurrence, but they do come with toxicities often. So it's important to look for ways to have effective treatments that limit with limited toxicities to patients who are getting this treatment. So this first study, the EA1181 study, also called the Compass HER2 study, was a study looking at the possibility of de-escalating treatment in early stage HER2 positive breast cancer. Currently, the standard of care for patient with stages 2 and 3 HER2 positive breast cancer involves giving a combination of chemotherapy as well as anti-HER2 targeted agents called monoclonal antibodies. We give that first before surgery. Generally, we give 6 cycles with chemotherapy, a taxane, whether it's paclitaxel or Taxotere. We give that in combination with another chemotherapy called carboplatin, and then the 2 anti-HER2 agents, trastuzumab and pertuzumab. So in this study, they enrolled over 2,000 patients, median age of about 55. And the goal was to assess what the response was going to be if we gave just 4 cycles rather than 6 cycles of chemotherapy to this patient. But then we also eliminated one of the chemotherapy drugs, and carboplatin was the drug that was eliminated in this particular regimen. So what they found was that the pathologic complete response rates, which means at the time of surgery, no cancer was evident in the residual tumor. In general, in total, was about 44%. However, in patients who were HER2 positive but ER negative and patients who had higher grade tumors, we actually found that those patients had better responses of over 60%. So this was a very exciting study for many of us, seeing that patients who are getting a de-escalated regimen of 3 drugs, and 1 drug being chemotherapy and the other 2 being non-chemotherapy, led to complete response rates in nearly 2/3 of patients with stages 2 and stages 3 disease, primarily in patients who had lower estrogen receptor expression on their tumor and patients who were high grade. And what was also interesting, there were additional molecular studies that were done. These are not studies that are standard of care at the moment, but they were using this molecular study to designate what we call a HER2-DX score. And patients who had a higher HER2-DX score also appeared to have higher complete response rates. So next slide, please. And so this is the schema of the study, and it's just a summary of everything that I just mentioned. And the summary and the conclusion of this study is that patients with early stage HER2 positive breast cancer could potentially get less chemotherapy with less cycles of chemotherapy, as well as actual less drugs included in their regimen, particularly patients who are high grade and patients who are estrogen receptor negative. So that is a conversation to be had, and this was a very exciting study. Now, this was a phase 2 study, which is a study where we're looking at just one group of patients. The next study that I'm going to discuss was essentially the same study, but they compared it to our current standard of care. And the findings were also quite exciting in the HER2 positive space. So if we can move on to the next slide, please. So the NeoCAR-HP study was very similar to the study that I just presented, where we're looking at de-escalating treatment. This was also a de-escalation study, but it was a phase 3 study rather than a phase 2 study that I presented earlier, which means they compared the current standard of care, which is a 4-drug combination, 2 chemotherapy and 2 anti-HER2 agents. They compared it with a 1 chemotherapy drug with 2 anti-HER2 agents, so a 3-drug combo versus a 4-drug combo. In this study, however, the patients also got 6 cycles, which is the current standard of care. And if you look at this slide, and this were all given before the patients then proceeded with surgery, the ability to assess what the response to chemotherapy was made after surgery was performed, because then the pathologist could review if there was any residual disease after receiving chemotherapy. And so what this NeoCAR HP trial showed was, if you look at the cartoon, if you want to call it that, on the right side of the screen, and you could see that patients who got the THP, which is the 3-drug regimen, compared to patients who got the 4-drug regimen, that the pathologic complete response rates were quite similar. Actually, the 4-drug combination had more neutropenia, which is lower white blood count, which is a side effect of chemotherapy. There were slightly more serious adverse events in the patients who got the 4-drug combination versus the 3-drug combination. And there were also less grade 3 to 4 adverse events in the patients who got the 3-drug combination compared to the 4-drug combination. So once again, this is a phase 3 study that basically mirrored the phase 2 study that I previously presented, but they were comparing 2 drugs. And what we saw here was that they were pretty comparable. This had a pretty decent number of patients included in the study. It was over 750 patients. So I think looking at the previous study and looking at this study, we're getting more and more information that dropping 1 chemotherapy drug and reducing potential toxicity from chemotherapy is likely appropriate in the in certain patients with early stage HER2 positive patients. They also found in this patients that those who were estrogen receptor negative and had higher tumor grade also appeared to have better responses. So I think for our patients that are HER2 positive who require chemotherapy before surgery, this is a conversation that can be had. Not everyone would be a good candidate for this 3-drug combination versus the 4-drug combination standard of care. But I think it's a conversation to be had, and I suspect there will be some changes in our current practice for neoadjuvant treatment in patients with HER2 positive breast cancer. So next slide, please. So moving on to the metastatic setting in HER2 space. For patients who are presenting with metastatic HER2 positive breast cancer, our current first-line treatment is a 3-drug combination with Herceptin, Perjeta, and a taxane, which has very good response rates, a very effective regimen. But the question was, we have this antibody drug conjugates now that we're using second line. And the question the study was asking, the Destiny 09 study, was, if we use the antibody drug conjugate called trastuzumab deruxtecan with the pertuzumab, and we compare it to our current standard, which is a taxane, so whether it's Taxol or Taxotere with trastuzumab and pertuzumab, which one of this regimen would have the better responses and would be more effective and potentially changing what our first line regimen is in patients presenting with metastatic HER2 positive breast cancer. And this study was quite exciting for everyone. And I think very soon we're going to be shifting our current standard of care, which has been the standard of care for more than 10 years, because the current regimen with the taxane, Herceptin, Perjeta is very active. Patients have very good responses, progression-free survival, and overall survival benefit with this drug. So what this combination showed when they compared our current standard of care with the antibody drug conjugate trastuzumab deruxtecan with pertuzumab, we found that the median progression-free survival was about 41 months with that new drug combination versus 27 with our current standard of care. And the 24 months, so the 2-year progression-free survival was 70% with the antibody drug conjugate trastuzumab deruxtecan with pertuzumab versus 50% with our current standard of care. So clearly, this is at least from the study, is a more effective drug, and it's very likely this will shift our current standard of care. I think we have so many effective drugs in the HER2 positive space, and metastatic HER2 positive breast cancer patients are living for many years. So to have a drug that actually allows patients stay on the same regimen for many years before switching at the time of progression, I think is likely to improve overall survival for our patients. We currently don't have overall survival data from the study, but we do have very good progression-free survival data that is likely to change our current standard of care. And it'll be, another few years before we're able to report on overall survival. But that is another positive study coming out of the ASCO conference this year. So can we move on to the next study, please? This is just the graphs showing what I summarized earlier, and you can see the overall response rates of the trastuzumab deruxtecan, the antibody drug conjugate with the Perjeta compared to our current standard of care. And you also see the progression-free survival curves, the blue being the study population that got the trastuzumab deruxtecan with the pertuzumab compared to the patients who got standard of care. Patients getting standard of care are doing very well as well. So, I mean, the data is very good in that setting, but to show that we even have what appears to be, based on this study, more effective combination, I think is very exciting for patients who are now living with metastatic disease where it's become a chronic disease, and having drugs that can really control disease for a long time. I think it is groundbreaking, and I expect that to be our standard of care very soon. So next slide, please. Okay, so this is the only study that on triple negative breast cancer. This was also in the metastatic setting. I think we're seeing so much in terms of over the last few years with immunotherapy and chemotherapy being used in the early stage triple negative breast cancer, and seeing pretty impressive response rates. And I think now it's trying to see how we can improve survival in metastatic triple negative breast cancer. And that's where this study, the ASCENT-04, this is why that study was done, which is looking at a drug called sacituzumab govitecan, which we currently use second line in our patients who are triple negative positive, and it was looking at sacituzumab govitecan with an immunotherapy drug called pembrolizumab, which we currently use in our first line in patients who are triple negative and PD-L1 positive. We give them chemotherapy and pembrolizumab combined. So this study was looking at how about we use this drug that we're using second line. It's also an antibody drug conjugate. Antibody drug conjugates are drugs that are designed where there's a chemotherapy drug that is combined with an antibody that is present on the tumor. So the drug binds to the cancer and to the receptor on the cancer, which then allows the drug sort of seep into the cancer cells and destroy the cancer cells. It's the sort of like easy way to explain what these drugs are. And because they're more targeted, they have generally less side effects compared to your standard chemotherapy. And they're generally more effective because they're also targeting a receptor on the cancer, or an antigen on the cancer, if you want to call it that. So some of our questions now are, there's drugs that we're using in second line, why don't we move them up to first first line in combination with some of the things that we're already doing first line. So this study was a global, was a multi-center, was also randomized. It was a phase 3 trial, and it was looking at sacituzumab govitecan, which we also call Trodelvy, in combination with pembrolizumab, and compared it to patients who getting chemotherapy and pembrolizumab. And these were patients who had the PD-L1, who were PD-L1 positive. It's something that's checked in the tumor, because we have data showing that in patients who are metastatic with PD-L1 positivity, they respond better to immunotherapy than patients who don't. So those were the patients who were included in the study. And the endpoint was looking at progression-free survival. The secondary endpoint would be to look at overall survival, overall response rates. And obviously that's data that will have to be gathered over years to get a sense of overall survival. So the findings from the study was really based on the progression free survival data. So if we can move on to the next slide, please. Thank you. And this is a very simple picture showing the results of the study. And you can see that the patients who got sacituzumab govitecan with pembrolizumab compared to the pembrolizumab and chemotherapy had improved median progression-free survival. They had slightly improved response rates, but their median duration of response was much longer than patients getting chemotherapy and pembrolizumab. And so there were more patients who discontinued treatment who were on chemotherapy compared to those who were on the study combination of sacituzumab govitecan and pembrolizumab. And so that tells you that this was a drug that was in combination that was more tolerable for patients. So we're seeing improved median progression-free survival, we're seeing improved median duration of response, and we're seeing less treatment discontinuation. And this also is practice changing and very likely will be first line for patients who are PD-L1 positive. So I think in the triple negative breast cancer space, which is generally a more difficult breast cancer subtype to treat because we do not have receptors that we can target, we're seeing immunotherapy drugs, we're seeing antibody drug conjugates really changing some of the narrative that comes with a triple negative breast cancer diagnosis. And it's always exciting and encouraging to see studies that continue to show activity in some of its newer drugs and prolonged and improved survival with some of this newer drugs. So I think there's still a lot we're going to be able to do in the triple negative breast cancer space, and I look forward to more studies and findings in our upcoming conferences. So if you can move on to the next slide, please. Thank you. So I wanted to talk a little bit about the SOFT and TEX trials, which focuses on estrogen receptor positive breast cancer. I'm sure a lot of people on here have heard about the SOFT and TEX trials. These are old studies. The studies were just sort of more of long-term follow-up to give us data on, 15-year follow-up, 20-year follow-up from when the studies were initially done. So the SOFT and TEX trials were studies looking at the potential benefit of ovarian suppression with tamoxifen or aromatase inhibitors such as anastrozole, exemestane, letrozole in premenopausal women with early stage breast cancer who had gotten chemotherapy, but then we're now getting adjuvant endocrine therapy. Traditionally, we were giving premenopausal patients just tamoxifen, and then the studies showed that if we also suppress this premenopausal women's ovaries to further reduce estrogen production, that this patients had improved disease-free survival and overall survival. And this SOFT and TEX trial basically suppressed the women's ovaries with gonadotropin releasing hormones such as Lupron and Zoladex. Those are the two drugs that we primarily use in this patients. And what the SOFT and TEX trials from 2011 had showed was that patients who got ovarian suppression and hormone and aromatase inhibitor. And once again, premenopausal patients with hormone receptor positive early breast cancer, that those patients had improved survival. And what this 20-year data is showing that is the survival continues to show improvement. And so this 15-year result of the soft and text trial just confirms what we're already doing. And it's always nice to, sometimes we do the studies and we stop at 5 years. We know women with breast cancer are living for decades. So it's important to see what's happening decades after diagnosis. So it's reassuring with the soft and text trial to show that that ovarian suppression and aromatase inhibitors continue to show improved disease-free survival, breast cancer-free interval, as well as overall survival for premenopausal women. So this is something that shows what we're doing is leading to improved survival, and we'll continue to do that. I thought, in the hormone receptor positive space, because survival is generally great. These are sort of better and lower risk disease for the most part. I think it's important to still, include hormone receptor positive breast cancer, at least in the early stage in some of our conversation. We often focus on triple negative breast cancer, which we absolutely have to. There are lots of exciting things in the HER2 positive space, but I think this is equally exciting to know that our patients continue to do well. And so that's it for early stage. And then for metastatic hormone receptor positive breast cancer, the SERENA-6 study was a very exciting study as well. And it was actually one of the studies that was presented at the plenary sessions. And so, they have a small number of studies that they think are so important, and they're presented at this plenary sessions where all the potentially practice-changing studies are presented. And the SERENA-6 study was designed for, and it was for patients who were metastatic hormone receptor positive. Traditionally, our standard of care is we start an aromatase inhibitor. We give a CDK4/6 inhibitor as first line. These are drugs like Ibrance, which is palbociclib, drugs like Verzenio, which is abemaciclib, and ribociclib, which is Kisqali. We give it in combination with an aromatase inhibitor, and they also are very effective. In the breast cancer world, we've been debating what the utility of what we call ctDNA, which is circulating tumor DNA, it's being used in other disease types, not quite yet in breast cancer, in terms of using it to actively make treatment decisions. And so this study was actually looking at the utility of circulating tumor DNA to guide treatment, and using that in changing our treatment rather than waiting for finding tumor progression on a scan. Normally for our patients who are metastatic, they start a treatment. Every few months we get CAT scans, and if we see any evidence of progression on imaging, then we change treatment at that time. This study was groundbreaking in the sense that the question was, can we actually change our treatment based on abnormalities that we're seeing in the blood that is suggesting that the tumor will become resistant to the drug the patient is currently on? Do we change treatment now rather than wait until we see progression on imaging and make changes then? It takes a while for tumors to progress and grow to a size that you find abnormalities on a CT scan or a PET CT scan. So the question is, if we're finding these abnormalities in the blood and we change treatment at that time. In this particular study, they were looking at a mutation in the blood called an ESR1 mutation. At the time of progression for most patients with ER-positive breast cancer who are on an aromatase inhibitor, the abnormality that would be found in that tumor is something called an ESR1 mutation. We see that in about 40 to 50% of patients who've progressed on an aromatase inhibitor. So if we're checking it before progression, and if those patients have that abnormality and we're putting them on a drug, and this study was a drug called camizestrant that we know targets tumors with that mutation, are we going to find survival benefit by doing that rather than waiting till progression? And what this study showed was that changing treatment at the time of abnormality detection in the blood rather than waiting for CT scan abnormality, led to progression-free survival benefit, as you can see on the graph. So the green was the patients who got camizestrant with the CDK4/6 inhibitor that the patients were on. The blue were the patient who continued on the standard of care, which is an AI with the CDK4/6 inhibitor. And as you can see in terms of the progression, median progression-free survival in months was 16 versus 9 in the patients who were on standard of care. And so this is very exciting, very likely practice changing, but there's still some tune-up that needs to happen to figure out how we're going to use circulating tumor DNA in breast cancer. And then what's important is knowing if this actually leads to overall survival benefit. So there will be more information to come, but the fact that we're now discussing using circulating tumor DNA in breast cancer, it is quite exciting. And I think is something for us to keep our eye out and ears out for how this is going to change our standard of care. But this is just a summary of what I mentioned about the conclusion of the study, that the early switch to camizestrant with the CDK4/6 inhibitor when an ESR1 mutation was detected during first-line progression showed a median progression-free survival benefit, at least at the first interim analysis. More analysis will be happening and we'll see what that will show. We don't have overall survival data as of yet, but the overall survival data that's pending will help us determine, what the advantage of using ctDNA to guide how we manage patients with metastatic or advanced breast cancer. But these are all very exciting, where, rather than waiting for progression on scans, maybe changing treatment when there is progression detected in the blood may actually improve overall survival. We will see what the study, what the data shows soon enough. So that is it. Okay, so that is it with the drug trials. I'm going to talk a little bit about OASIS 4 trial. This is more focused on survivorship, and this was a study looking at how, what interventions are available for patients who are dealing with vasomotor symptoms, which we call hot flashes from the anti-estrogen therapy that they're on. Most breast cancers are estrogen receptor positive. About 65% of breast cancers are estrogen receptor positive, which means about 65% of patients who've been diagnosed with breast cancer will be on an anti-estrogen therapy. Because we're reducing estrogen in the body, some of the side effects from having less estrogen are, we talk about joint pain and muscle aches and bone health, but hot flashes are a big thing that patients do complain about. Currently, we recommend things like physical activity, exercise, acupuncture, low-dose antidepressants. Those are some of the things that we use to mitigate the symptoms associated with, the hot flashes. And this study looked at a new drug called elizanittant. It's evaluated the safety and efficacy of the drug in women who are being treated for breast cancer and who are dealing with really moderate to severe vasomotor symptoms while on their anti-estrogen therapy. What's exciting about this drug is it's a non-hormonal drug, and it really regulates estrogen sensitive nerves in the brain. These are nerves that become hyperactive when estrogen is decreased in the body during menopause and when you're on a medication that reduces your estrogen levels, and that leads to some of this hot flashes, which could be debilitating for some patients. So in the study, they randomized the patients to receive the drug for 52 weeks. The other group were on a placebo for 12 weeks, and then they were switched to the drug for 40 weeks. And the goal of the study was to look at the change in the, frequency of the symptoms of the hot flashes from baseline to, 4 weeks and 12 weeks after being on the medication. So if you can move on to the next slide, please. And so as you can see on this graphs that I have on here, the patients in blue are the placebo and the patients in yellow are the patients that were on the study drug. And you can see that the change from baseline was significant in patients who were on a study drug. So the first graph is looking at the decrease and the change in frequency of moderate to severe motor symptoms. The second graph was looking at severity so they looked at from week 4 and then week 12. And they also looked at some of the menopause-specific quality of life symptoms. And you could see that in patients who were on the study drug, the decrease was significantly less. And then the patients who were on the placebo, who got switched over to the drug at week 12, you could see that then the decrease also happened once they were on the drug. And this was definitely impressive enough for the drug to now be FDA approved for patients who are dealing with vasomotor symptoms or hot flashes. So it's nice and it's great to have additional tools in our toolbox, in addition to our recommendations for patients to drink less alcohol, because that can worsen hot flashes, to consider complementary interventions or integrative medicine interventions, such as meditation and acupuncture, using low-dose selective serotonin receptor inhibitors such as venlafaxine. We also do have this drug now that we can use for patients who are dealing with severe symptoms of hot flashes, vasomotor symptoms, as we call them. So I think in the survivorship phase, and it's nice that we're doing studies that are looking at patients in survivorship, because patients are really thriving and living past a diagnosis of breast cancer, but some of our treatments are still causing quality of life impact and symptoms, that it's also important to address that and look at studies to allow patients continue to live with a good quality of life after they've been done with active treatment for breast cancer. So we can move on to the next slide, please. Okay, so this is a surgical study, and I put in 2 studies together because they were basically talking about the same thing. And once again, it's this trend of looking for ways to de-escalate not just our medical therapy, but also de-escalate our surgical interventions. So this study, the SOUND and the INSIMA trials, were looking at de-escalation and possibly omitting sentinel lymph node biopsy in certain patients with early stage breast cancer. And these are patients who at the time of assessment had negative lymph nodes on their ultrasound. And the studies were looking at if it was possible to omit a sentinel lymph node biopsy in some cases, and if we can do that safely. We do know that patients who get sentinel lymph node biopsy, although the potential for lymphedema and pain and some of the things that are associated with an axillary lymph node dissection is significantly less than patients who are just getting a sentinel lymph node biopsy. But we know that patients who do not get a sentinel lymph node biopsy generally experience less pain, less wound infection, less axillary cording. It's this sort of like tight vein that patients sort of feel under their arm after surgery sometimes. And obviously lymphedema is rare with the sentinel lymph node biopsy, but there are cases of lymphedema from that. So the question is, how do we actually eliminate this altogether if possible, and identifying patients who may not necessarily need to have a sentinel lymph node biopsy? And that was the purpose of the study. If we could move on to the next slide, please. And so based on the findings of the study, actually, ASCO now has guidelines which were put out this year as well, that sentinel lymph node biopsy can actually be omitted in certain patients. So this is one that requires a high-level conversation with the breast surgeon, because it's not for every patient. But patients who have small breast cancers, less than 2 centimeters, patients who do not have any axillary lymph node finding on their preoperative axillary lymph node ultrasound, patients who are postmenopausal, patients who have just one focus of disease. So if there's multifocal disease, which means there are multiple areas of cancers, even if they're small, these are not the patients that you would consider this for. Patients who have low-grade tumors, so your grades 1 to 2, and patients who are hormone receptor positive. It does not apply to triple negative or HER2 positive breast cancer patients. So in this patient, it's important to have a conversation about potentially eliminating surgery. But I think the fact that this is now part of the conversation, it was never part of the conversation. Everyone who had a lumpectomy automatically got a sentinel lymph node biopsy. So to have a group of patients who may be able to avoid that and hereby reduce the risk of some of the potential side effects associated with sentinel lymph node biopsy, it is quite exciting. So those are the current guidelines from a surgical standpoint. So if we can move on to the next slide. And this is I think this would be my last study, actually. And this was, I think, one of the most important highlights, particularly for our survivors. You know, we give patients anti-estrogen therapy because the breast cancer, once again, feeds off of estrogen, a way of reducing the risk of recurrence in patients who are hormone receptor positive is to put them on anti-estrogen medications such as tamoxifen and aromatase inhibitors. They do have potential side effects associated with them that, like I mentioned earlier. One of the biggest complaints that we see in patients is that they struggle with genitourinary symptoms. So patients who are on tamoxifen and the aromatase inhibitors such as anastrozole, letrozole, exemestane will sometimes complain of vaginal dryness. Vaginal dryness can increase the risk of urinary tract infections. It can sometimes lead to painful sexual intercourse. And so we generally have traditionally recommended anti-estrogen interventions, water-based lubrication, water-based moisturizers. But we have studies that, you know, show that topical vaginal estrogen actually does not increase the risk of breast cancer in patients who have been diagnosed with breast cancer and using topical estrogen. But the application of what the studies have shown is not very is not uniform. You know, we have previous studies that I mentioned show no increase in breast cancer specific mortality, but patients are afraid, and patients also receive conflicting advice about potential risk of breast cancer if they're using topical hormonal based products. So this study that I thought was, at least for our patients and survivors, was a retrospective study looking at the SEER database as well as the Medical Health Outcome Survey. They looked at almost 20,000 patients diagnosed between 2010 and 2017. They compared patients who were diagnosed with breast cancer and were done with treatment with breast cancer, who used local vaginal estrogen, to those who did not. Next slide, please. And what they found was that among breast cancer patients who used vaginal estrogen compared to those who did not, they actually found that there was increased overall survival in those patients. They found increased breast cancer specific survival. And they did not find, when they did the subset analysis, we did not find any increase in breast cancer in patients who used vaginal estrogen compared to those who did not. So there was they did actually found an increase in breast cancer. There was no significant increase, in breast cancer specific survival. And I think for patients who've been told over and over or have read that, you know, topical vaginal estrogen could increase the risk of breast cancer, I think, you know, we do have smaller studies that show that there's no increased risk. I think this retrospective study with almost 20,000 patients is reassuring. And so I'm hoping that patients are feeling more empowered to ask if they're having symptoms that are debilitating as it pertains to genital urinary symptoms of vaginal dryness and painful sexual intercourse and all the things that come with being on endocrine therapy for some patients. There is data showing that the risk of breast cancer is not increased. And so, and the topical estrogen actually works better than many of the other things that we recommend over the counter. Those things do work for many patients. So that's usually the first line, But for patients who've tried the non-estrogen topical agents and still continue to deal with genitourinary symptoms, it is safe to use vaginal estrogen, topical estrogen. The amount of estrogen in this topical agents is very minimal and barely getting into the bloodstream. And as we see in this retrospective study, it's not increasing the risk of breast cancer in this patients. So my next slide. So this is my very last slide. And I think just important for those on here, my take home is that we have very exciting findings showing that in some patients, we can de-escalate treatment in the HER2 positive early stage breast cancer. There's a role for de-escalating neoadjuvant chemotherapy. So it's a conversation to have with your medical oncologist, the possibility of omitting carboplatin, particularly for patients who may have underlying medical issues that makes it difficult for them to tolerate some of the drugs that we are giving first line, that one could make an argument for eliminating those drugs in the appropriate patient. And then the next take home is that elizanitant is now FDA approved. It's an FDA approved medication to reduce the common side effect of vasomotor symptoms. For those who are struggling with it, this is something to consider if all else fails. Also in patients with a previous history of breast cancer, the use of local vaginal estrogen to reduce genitourinary symptoms does not increase the risk of breast cancer recurrence. I know it says does, that's definitely a typo, does not increase the risk of breast cancer recurrence. So it's important to discuss the use of topical vaginal estrogen if conservative measures aren't effective. So the non-hormonal moisturizers, if they're not effective, this is something to consider. And for postmenopausal women with small tumors, negative axillary lymph node on ultrasound, low-grade hormone receptor positive, they may be able to avoid sentinel lymph node biopsies at the time of their breast surgery, and that is a conversation to have with their breast surgeon. And that is the very end of my talk. Thank you for having me and listening to me.
You're amazing. Thank you so much. So definitely have some questions for you, Dr. Taiwo. Obviously huge advances in early stage HER2 positive and metastatic breast cancer. And so, one of the questions we had previously received, which you did talk about, was how treatment has changed, but this person specifically said since 2011. And so, with those first two studies that you mentioned, when did they start? What year did they start? And I know that for the EA 1181, that the age range was that 22 to 88 years old. Was there like a racial or demographic breakdown within that study?
There was a breakdown, and I think unfortunately, like most studies, women of color are still underrepresented in many of the studies. There is a trend towards including more women of color, so it's actually nice to see some of the changes. A lot of what I do actually is really trying to figure out how to include and encourage women of color to be included in and participate in clinical trials. People do have reservations about it. So there was a breakdown, and it's still not at the same, it's still not representative of the current demographics, but I was encouraged, but not close to where we need to be. So that's the simple answer to that. But they did not break down response based on race, or it was just based on the stage and based on the regimen that the patients were on. And I don't know that they even had enough of a number to actually be able to make an assessment as to, oh, this group of women responded better than this group of women. It was empowered to show that. Yeah. But the study definitely, and we actually had that study opened here. My cancer center, I'm in Brooklyn. Majority of my patients are Black and Latino women. The women that we included in the study were primarily Black women on the study. And we also saw very good responses in the patients that we included here. So even though the study is not representative of the demographics, I don't want people to feel like it doesn't necessarily apply to them. Even from our small group of patients here, we did see good responses with the de-escalated regimen in the appropriate patient, which were patients who were primarily ER negative and had higher grade tumors.
You know, because I always think about those in rural areas and how do we reach them and how do we make sure that we get the information about these study updates to those doctors. Um, so what kind of, I guess, questions can patients ask their oncologist? Like in thinking of that study and the Destiny, no, the Neo
Your
CAR.
CAR HP?
Yeah,
Yes.
like what kind of questions can patients ask their oncologist, like about like those two studies? What are things that they should do if they have that same um, type of mutation or what
Right.
have you?
No, great question. And I think it's the same question you should ask your oncologist at all times. It's asking, what is the latest? What's the update? I'm aware that there's certain patients who may be able to, you know, avoid, you know, heavy duty regimen. I'm aware of the fact that there's data showing that in certain patients, treatment can be de-escalated. Am I in that category where I can avoid, you know, your current standard of care? It's very possible the oncologist may have already decided that you are appropriate for that, and that's actually the plan. And then they're able to say, absolutely. And the plan actually is this is standard of care, and based on your tumor type, we think we can sort of de-escalate your treatment. But I think any initial visit and any follow-up visit and any time there are changes being made in a treatment regimen, whether you're early stage, metastatic, survivorship, I think the question should always be asked, has anything changed, since the last time I was treated? Has anything changed with this treatment that you want to put me on? Are there any clinical trials that I may be potentially eligible for? And I think that kind of question forces your oncologist to make sure that they are up to date and make sure that they are making the best recommendation for you and your tumor type. So I think it's the same questions I tell patients to ask at all times. What's the latest?
Hmm.
And I think, what Share does by educating, patients and outreach, I think gives patients, you don't need to be an oncologist. You just need to be aware that there are some changes. We're moving and trending towards de-escalating, and then just asking, am I one of those who could have less intense treatment?
I mean, because that's really what it's about is that less toxicity,
Mhm,
right?
mhm.
So I noticed that because someone asked, what are recent advances that pertain to invasive lobular? I am also an invasive lobular survivor. Were there any updates for that subtype?
So not quite, because right now we treat invasive lobular the same as we treat invasive ductal, right? And so I think doing a study where you're separating lobular from ductal may be difficult. Obviously, most breast cancer subtypes are ductal. And so I think it would be a smaller number, but we do and are aware that there's certain features about lobular that actually makes it a bit more of a difficult tumor type. And I think as we're recognizing this more and more, I think there will be an observation of how lobular patients are doing. Generally, they're getting the same treatment. And I think what we find, it's more about the diagnosis, less so than the response. Lobular, because of the way the tumor grows, it kind of, tricks you. You may not see
Mhm.
it on a mammogram. I think the fact that we're now doing more MRIs as screening for high-risk patients, I think a lot of breast surgeons are also asking for MRIs even to guide surgical planning. We're doing that as well for lobular patients because we know it's a tricky disease. What I'm hoping for is that we're able to identify the disease a lot sooner and that we're able to get a sense of the extent of the disease so patients are not being undertreated or they're not being overtreated because we're always scared of lobular. But right now, yeah, we don't have studies that are separating the two. We just sort of like still categorize breast cancer based on the receptor status, based on the molecular subtype, right? And that may change in the future, but not at the moment. But yeah, lobular has its
It
challenges.
exactly known as the sneaky cancer.
Yeah.
And that honestly, the only time I ever feel, because I am 9 years in survivorship, I was diagnosed under 40. And the only time I feel like I can trust my scans is when I get the MRI.
Yeah. Yeah.
Yeah. So we also had someone ask, they're having a hard time finding trials that help to prevent a recurrence. And out in, like I like to say, instead of prevent, lower that risk,
Mhm.
because they did have a recurrence in their local regional nodes.
Mhm.
What can we do, or what can be done to help lower that risk of recurrence?
Yeah, I mean, I think, the standard recommendation, for patients is if it's hormone receptor positive, like we showed in this soft and text trial 20 years later, that patients who are endocrine estrogen receptor positive on the drug, particularly premenopausal, really do benefit from ovarian suppression. We know being on anti-estrogen regimen is a way of reducing recurrence. I think what's going to change the game is potentially utilizing circulating tumor DNA. Breast cancer tumor markers are not very reliable, so we don't use tumor markers per se. We don't scan because it hasn't been shown to be very useful in early stage breast cancer. So a lot of our follow-up in the survivorship phase is checking your blood work periodically. How are you doing? Your physical exam, maybe scans if we think we see abnormal labs. But I think if we're showing that circulating tumor DNA may be useful in the metastatic setting, that's how changes often start. We do something in the metastatic setting, then it's sort of recreated in a different way in early stage. So I think if we now get to a point where we're able to start checking and we have data showing that circulating tumor DNA in the early stages beneficial, we may be able to catch cancer in the blood before it actually presents with the positive lymph node or local regional recurrence or metastatic disease that may be intervening when there's something in the blood before it shows up on a scan may eventually be how we also further reduce recurrence. Those are studies that are actively ongoing. So I look forward to seeing what the findings show. But for now, it's the routine. You got to stay active, exercising, eat well. If you need to be on endocrine therapy, stay on the endocrine therapy. For patients who are smokers, we say abstain from smoking. If you drink alcohol, decrease the amount of alcohol you drink. All those things we know reduce the risk of recurrence. Obviously, then we need to do more clinical trials to look for other ways that we as clinicians, as researchers, could also help reduce the risk of recurrence. But I do think molecular studies and circulating tumor DNA is likely going to change the way we practice. We just need the data to show that first.
Hmm. Well, I was excited to hear that there was a trial for survivorship, because there is a gap in kind of like that survivorship care of like, well, hey, a lot of us have experienced major debilitating side effects, right? And someone even mentioned that the side effects of tamoxifen for some, like including myself, I could not tolerate the bone pain, and it was so debilitating. I actually couldn't walk. It felt like fire ants were crawling on my chest and my neck and my arms, and I actually could not take it anymore. And so I'm thinking about the study that you mentioned before I get to the hot flashes of the ovarian suppression. Did they talk about um, fertility discussions with the patient within that study? Like, had they all had that conversation before going through Lupron injections?
Yeah, I mean, I think that was not because this patients who are getting ovarian suppression and an AI or TAM were obviously high risk. So the conversation, and at the time the study was initially done, fertility was not really part of the conversation. It was always, you have breast cancer. If we're going to talk about fertility, maybe you freeze your eggs before you get chemo and whatnot, and then we figure out how you can, proceed with having children if that's something that you desire. I think that's going to become part of the conversation now, because a couple years ago, also at ASCO, the positive study, which was a study looking at this young women who were either on ovarian suppression and an AI or tamoxifen, was looking at the risk of breast cancer recurrence if you stopped the endocrine therapy after 2 years to allow this young women to go start families that they so desire, and then put them back on their treatment once they've had children. And that study didn't show any significant increase in breast cancer recurrence. It's still pretty early. I think we're going to hear more and more about how this women did over time. So I think, you know, we're now at a point where there's so much in terms of survival, patients are doing so well that
Mhm.
we're all now thinking, okay, how do we make sure this patients have a good quality of life? How do we make sure this patients who want to have children can have children in a safe way? So I think you're going to start seeing more survivorship studies because patients are now doing really well. Early stage breast cancer, the prognosis is good for most patients. So I think some of the questions that you're asking, which are important, will be answered now that we know that patients, the drugs we have in our treatment plans and management are pretty effective for most patients. Okay, what comes after all of this? How do you have the kind of life you want to have post a breast cancer diagnosis? So I'm excited to see what we're going to find in the future. But fertility is a huge part of our conversation now. 20 years ago, 25 years ago, it wasn't.
Mhm.
It wasn't. Now we're oh, we want to start chemotherapy in 2 weeks. We got to make sure you see the fertility specialist. They need to get all your fertility treatments. We need to harvest all your eggs before we start treatment. We literally plan around it. If you're 25, 30, under 40, you don't have children, a breast cancer diagnosis, particularly if it's early stage, should not be a reason to not attempt the kind of life that you want, particularly since we know it's likely you're going to do well.
Mm.
Right. So,
I think this is a beautiful way to end this fabulous presentation and discussion, and like the importance of ASCO and what patients can learn from it. I feel hopeful in hearing what you said, and how you just ended that on a hopeful note for those of us who are in that survivorship stage, but also those who are in treatment, depending on your age and that fertility conversation. I just feel very hopeful in where the research is going. So anyone, if you have other questions that you think of once this webinar is over, do not hesitate to reach out to us and we will get those answered for you. I want to thank everyone for joining us today. And again, thank you, Dr. Taiwo, for your expertise, your thoughtfulness, and the answers to the questions. And again, we will have a recording of this program available on our website in 1 to 2 weeks. So please make sure to check out our website. As you see, we have some upcoming events. So on Monday, we have managing lingering side effects after breast cancer, what's normal and when to get help. What to do when insurance companies say no in August, and our Let's Talk About It, August 27th, for breast cancer in general, tapping into resilience, and our Let's Talk About It for Black women at summer check-in. Let's plan and talk together. Also have a writing workshop. Next one is in September, and don't forget, if you need support, we do have our helpline. That is a resource for all. So we're just a phone call away. And also, there will be a survey that pops up at the end of this webinar. Please take it. Write your feedback. Your voice is what helps guide our topics, and you matter. This concludes the webinar. And again, thank you, everyone who came. And thank you again, Dr. Taiwo, for your fantastic presentation. And we hope everyone has a great weekend.